everybody, and welcome to Clinical and Statistical GC Young and Journal Club Corner. This is our first episode after summer stop, and I'm very happy to share this moment with Vincenzo Fioretti, which is my colleague from Cardarelli from Naples, and our expert Simone Biscaglia from University of Ferrara. Today we will talk about a very hot topic in interventional cardiology, which is NSTEMI in older patients. Vincenzo will present us a clinical case, very interesting, and there will be, I hope, so much discussion about the clinical and interventional management of this patient. And then Simone will talk us about Seniorita, which is a very important trial, which every one of you know has been presented in ESC Congress in August, and the FIRE trial, which is another really important trial, and we are glad to have Simone, which is the presenter and one of the main names of this trial. So I think we can go on, and Vincenzo, please share your case with us.
Okay.
Sorry, one last thing. Everybody we can make answers in chat or raising hand, and I will read every of your question at the end of the presentation. Then we will have a brief discussion. Go on, Vincenzo, sorry.
Okay. Good morning, everyone, and thank you so much, Federica, for your presentation. It's a great pleasure for me to present a case regarding the management of non-STEMI in an older patient. So now let's start with our case. The case is about a female, 82 years old, admitted to our emergency department for chest pain. The patient had multiple cardiovascular risk factors, including hypertension, dyslipidemia, severe chronic kidney disease, and prior ischemic stroke. Among the comorbidities, we found anemia, atrial fibrillation, and a prior breast tumor. Moreover, the patient was classified as mildly frail according to the Rockwood Frailty Scale, and no cognitive impairment was present. The electrocardiogram that was done in the emergency department revealed negative T waves in inferior leads. Echocardiography revealed a mild reduced left ventricular ejection fraction with hypokinesia of inferior and inferoseptal walls. Laboratory tests revealed an increased troponin. So our diagnosis was of non-STEMI with the Grace risk score of 150. So according to the latest European guidelines about the management of acute coronary syndromes, it is recommended to apply the same diagnostic and treatment strategies in older patients as in younger patients. Moreover, for frail older patients with comorbidities, it is recommended to individualize the treatment after the evaluation of the risks and benefit. In our case, we decided to perform coronary angiography, and right coronary artery angiography revealed a long critical stenosis in the mild distal segments. Left coronary artery angiography showed an intermediate stenosis in the mild segment of left anterior descending artery, and moreover, the left anterior descending gives collateral circulation for the posterior descending artery of right coronary artery. Moreover, we have a critical stenosis in the proximal segment of the first obtuse marginal and in the mild segment of the circumflex artery. So, in conclusion, we have a patient with multivessel disease with NSTEMI, and she's an older patient. This is a common situation in our practice. So, how should we treat this patient? Optimal medical treatment or PCI? And revascularization of the culprit-only vessel or a complete revascularization, and how to guide the choice of non-culprit vessel revascularization, angio-guided, physiology, or intravascular imaging, and moreover, the revascularization in one procedure or in more procedures.
Okay, so now we have a little stop because we want to listen to Simone's point of view. Of course, this is a very frequent patient. In our experience, me and Vincenzo, we work in the same hospital, but I think that every one of you has encountered every day this kind of patient. So Simone, which is your management in your center, and according to your experience, which is the best treatment for this kind of patient?
Yeah, thank you. Thank you for having me this morning. So I think that we have many questions to answer. The first one was if to perform coronary angiography or not, and Vincenzo decided to do an invasive treatment, and I agree with that because the patient had positive troponin, typical chest pain, and high GRACE score. I don't remember the EKG, Vincenzo. What was the EKG? Did you find anything?
Negative T waves in inferior leads.
Okay. And also EKG was modified. So I completely agree with the invasive treatment and with the fact that the invasive treatment was performed early after the symptoms. So within 24, 48 hours between the beginning of the symptoms and the angio, if I correctly remember. And so this is the first point. The second one is if to perform PCI or not. I think that you clearly shown by the angio that there are several lesions. And probably I think that if you decide to go with the invasive, then you should do something different than the Signorita investigators that performed coronary angiography but not PCI. So if you embrace a strategy, I think that you have to go 100% with it. And I think one of the most important issue in this case is to decide which one is the culprit lesion. And this is a very important point in the non-STEMI setting, because in some cases it's not so easy. In this case, you may have to think that the right is the culprit, but also the obtuse marginal could be a contributor to the instabilization of the patient. And so the first point is to decide which one is the culprit lesion. If you think or you have any doubt regarding the fact that there can be one or more culprit lesion, because in 15 to 20% of non-STEMI patients you have called a culprit, and so you have to treat both. So in this case, if you are 100% sure that the culprit is the right, you can go with the right. But if you have any doubt that the obtuse marginal can be a contributor to the stabilization of the patient, then I think that you should think about the co-culprit in the obtuse marginal. And then as for the management of the non-culprit, and so in this case it would be the LAD, in my mind, what I would do is to perform physiology because of the FIRE trial, basically. And the last point is how to guide PCI. No, there are 2 points. How to guide PCI. If I use physiology, I would optimize the PCI with physiology in case of PCI in the non-culprit, obviously. And then in this case, in non-STEMI, the best way for me to perform physiology would be with the wire-based technology because of many reasons. The first is that you can perform a pullback, so you can understand the pattern of disease and where the focal step-up is, if there is any focal step-up. If there is a very diffuse disease, then you may also think about going on only with medical treatment. And also you could perform, if you have the wire with the temperature sensor, you can perform the evaluation of the microcirculation. You are in the setting of an MI, so you want to know whether a borderline FFR with a very focal lesion is associated with a high IMR, so with microvascular dysfunction, and then you may also decide to go on with stenting, even if the FFR is 0.81. I mean, you have many more information that you can gather from a case like that. As for one time of staged, in this case, the patient had high creatinine. I think it was around 2. So it depends on how much contrast you use in the treatment of the culprit. If it's not much, you can perform the physiology. And if the physiology is negative, you close the patient only in one procedure. That is better for the patient. But if you use a significant amount of contrast for the treatment of the culprit lesion, then you may want to stage the non-culprit, especially if it's positive.
Okay, thank you, Simone. So many things to see. And so, Vincenzo, go on. Let's see how you manage this case.
Okay. In our case, in the same procedure that was done before the 24 hours from the admission, we decided to perform a right coronary artery PCI that we identified as a culprit lesion due to the electrocardiogram and also to echocardiography. So we performed the PCI of right coronary artery with the stent placement in the mid-distal segment of the artery, a stent 2.5 millimeter, and a subsequent post-dilation with a non-compliant balloon 2.75. We decided to stop our procedure, and due to the more contrast that was done, and we decided to perform a staged procedure 3 days after the index procedure. In this procedure, we performed the PCI of the first obtuse marginal with the stent placement in the proximal part, stent 2.5 millimeter, and the post dilation with the non-compliant balloon 2.5 millimeter. We decided not to perform the PCI of the circumflex artery due to its small diameter and the small extent of the vessel. In the same procedure, we assessed the functional significance of the left anterior descending stenosis using FFR, which revealed a non-significant value. So the patient was discharged a few days from the staged procedure, and at 1 year follow-up, the patient had no cardiovascular events, and she was asymptomatic for chest pain. Echocardiography revealed a normal left ventricular ejection fraction. So our patient could be considered one of the enrolled patients in the Señorita trial that is a prospective, multicenter and randomized trial that was recently presented at the European Congress in London. Patient enrolled in this trial included the patient with an age aged 75 years old or older with the type 1 non-STEMI. Exclusion criteria including STEMI or unstable angina, cardiogenic shock, and life expectancy before 1 year, and inability to undergo invasive coronary angiography. Enrolled patients were randomized to a conservative treatment or invasive treatment, and they were evaluated for a median follow-up of 4 years. In patients randomized in the invasive treatment, angiography was performed in 90% of patients, and multivessel disease was present in more than half of the patients. Moreover, revascularization was performed in about half of the patients, and in 30% there was a multivessel PCI. Another important finding of this trial is the safe of invasive procedure in elderly patients. In fact, the percentage of a procedural complication was of less than 1%. So in the follow-up, the primary endpoint that was a composite of cardiovascular death or non-fatal myocardial infarction revealed no significant difference between the conservative and the invasive treatment. The same was for the cardiovascular mortality, so no difference between the two treatment strategies, but the non-fatal myocardial infarction, the incidence was reduced in patients treated with invasive treatment. The same was for the subsequent revascularization.
Okay, thank you, Vincenzo. Very interesting case. Now we want to ask Simone. We have just this spoiler table, which talks us about Senorita, of course, this important trial, which tells us that perhaps is not so good to take invasive coronary angiography to all the older and STEMI patients. But what is, in your opinion, the message which Senorita gives us comparing to FIRE trial?
Yeah, I think that there are many things that we can understand and learn from the Senorita trial. And the first one is that if you do an invasive strategy, it's very safe because the rate of complication was far lower than 1%. So this is a very good message. The second one is that if you want to perform an invasive treatment, you have to do it within 48 hours since the beginning of the symptoms, because in the Senorita trial, patients were randomized after 3 days after admission, and the time between admission and coronary artery angiography was 5 days. So then obviously it's not an acute treatment, it becomes an elective one, basically. And the third point is that if you want to perform an invasive strategy, you have to perform PCI, because as Vincenzo said, only 50%, less than 50% of the patients included in the invasive arm received actually PCI, and the type 2 MI was an exclusion criteria. So it's either that many patients were included because of type 2 MI, and that is an issue of the study because it means that not representative of the type 1 MI population. The other possibility is that they didn't perform PCI in culprit lesions. So again, it's not invasive. Invasive treatment means treatment of the lesion, not performing coronary artery angiography. It's not a treatment. Coronary angiography is a diagnosis. If you don't follow the diagnosis with the treatment, then how can you think that the patient will have a better prognosis? And another point is that only if you have a look at the patients that were excluded by the trial because of the clinician decision, 66% of those patients received the invasive treatment and PCI. So again, it's highly likely that the investigator decided to treat the higher risk patient with probably, EKG alteration, high rise in troponin with PCI without including them in the trial. And so obviously then you dilute the benefit of the invasive strategy once again. And only 27% of multi-vessel disease patients receive PCI in more than one vessel. So this is another very important point. If you perform an invasive strategy, you have to first perform PCI in the culprit, but then if you have a non-culprit lesion, it's important because of the FIRE trial to have a complete revasc, because this impact on mortality. So again, I think that it was, I would say, a miracle that MI were reduced. And this is, again, a very important point, because by performing coronary artery angiography and some PCI, you reduce MI. I mean, if you would have performed PCI in the culprit and PCI in the non-culprit, I think you would be like an islander. And the last point is that probably, I don't know if the mortality at 4 years is the best endpoint in an older patient population, because the mean age was 82 as the patient of this case. So I don't know if we have to look for long-term mortality if we want to, you know, create new islanders in our clinical practice. Or the most important thing is that when we treat a patient, we try to optimize also the quality of life, the freedom from hospitalization, and for sure, the reduction of MI and subsequent revascularization is an important point in terms of the quality of life of the patient, of the relatives, of the caretaker, because in patient 85, 87, there is a, you know, a village around the patient. So it's very important for them to stay away from the hospital, to have, if it's possible, an independent life, and try to maintain things as long as possible in this way. So I think that those are things that were known also before the Signorita, because the meta-analysis of all the studies on the same subject gave the same results in terms of benefit of the invasive strategy in terms of mortality in patients who received early invasive treatment, who had a high rise in troponin, and who had a grade score more than 140. In the Signorita, it was lower, it was 135, the mean grade score. So I think that it's very reassuring. And if you put together the Signorita and the FIRE, I think that you have a good idea on how to manage a patient with the non-STEMI. Obviously, you have to, as Vincenzo said, you have to treat the single patient. So in patient with, you know, cognitive impairment, with high degree of frailty, you can think, especially if the rising troponin is small, if there is no, the grade score is not so high, also to have a conservative strategy. And we thank the Signorita investigator for this information, because it could be important in some cases, but I think that in most of the cases, this would be the way to go.
Okay, thank you, Simone. I think that before starting with discussion, we can just end with our take-home message. And if Vincenzo is okay, I think we can ask for to take.
Yes, that's basically what we said. Invasive treatment is safe. You should go for complete revasc. Treat the culprit and then go with the complete revasc. You can think of a conservative strategy in very compromised patients, in patients with many comorbidities, with reduction in the life expectancy because of non-cardiac comorbidities. And you always have to look out for the patient you are actually dealing with. So it's very important to understand also which are the characteristics of the patient, and in order to try to tailor the strategy on the very patient you are treating.
Okay, thank you. I have a question for you, Simone, because I already know Vincenzo's answer, so that we work in the same place. But when you have this kind of patients, and we have a atrial fibrillation also in this lady, what is your approach for triple therapy? So we try to reduce metal with FFR and to stent only really significant hemodynamically significant lesion, but so that we have to put stent. What is your approach for triple therapy? You how long? For how long?
Yeah, that's a very good question. So in the FIRE trial, we actually looked into that question, because in HBR patients, we suggested to have a short APT regimen, meaning 1 month of the APT in patients in oral anticoagulation, and mostly 1 week, probably 3 or 5 days of triple therapy in patients on atrial fibrillation. And what we saw in the trial was that these patients, if compared to those patients in whom the investigator were deciding not to go with the strategy that was suggested in the protocol, so they decided to go with the longer triple therapy or dual antiplatelet therapy, the benefit for the patient with short EAPT was consistent. So it was especially a reduction in significant bleeding without paying a price of MACE. So I think that from that, my strategy, even in these patients who are those high dual risk, because they are very high ischemic risk, because they are MI patient, older patient, multivessel disease, but the bleeding risk comes first, as we understood in the last years. And so what I would do is to perform a very short triple therapy within the hospitalization and to discharge the patient on double therapy, so anticoagulant and oral antiplatelet agent. And then after mostly 6 months, withdraw the second antiplatelet agent and go on with only anticoagulant treatment.
This is a very important message, Simone, because I think that every interventional cardiologist tends to be really aggressive talking about triple antiplatelet therapy, and we have a gastroenterology department down floor, and every kind of patient which comes back with gastrointestinal bleeding, they call us and tell, what have you done with your triple therapy? So this is a really important message, especially for older patients.
Yeah, you have to be very careful because you are actually going against the guidelines. You have to know that because the guidelines said the 1A that you should do 12 months of dual antiplatelet therapy in my patient, but this is not evidence-based. So basically, I think that you have to follow the evidence, and the evidence clearly states that if the patient is high bleeding risk, you should go with the lower DAPT regimen.
Okay, we have 2 questions. Which is the benefit of microcirculatory assessment in acute setting? I think this is for you, Simone.
Mm-hmm. Yes, that's what I was trying to tell before. So if you have microcirculatory assessment in the setting of MI, is important because you are reassured if the FFR is negative that if the IMR is normal, the evaluation is good and you are good to go. On the contrary, if you have a very high degree of microcirculatory dysfunction in the setting of acute MI, especially if the MI is big, is on the LAD and so on, you may think that you underestimate the value of FFR. And so in cases, for example, if you have an FFR of 0.81 with the focal step up of 15 points of FFR in a tight lesion in the proximal LAD, and you have an IMR of 50, you may think that in a couple of days, in 1 week, you will have a lower value of FFR because the microcirculation will get better after the MI, also in the non-culprit in the non-culprit territory. And so you may think, if you want to go with the stenting, even if the FFR is borderline. So I think it's something that takes the use of physiology in the full physiology way, so more than just a number of green light or red light. It's important because then you can decide which is the best strategy for the single patient. Again, try to tailor the treatment for the single patient. If you have an FFR of 0.79, but you have a completely diffuse gradient at the pullback, then you know that you won't obtain much by PCI. So you may also could think of leaving the patient just in very aggressive secondary prevention. So I think that this is in general a new way of use physiology by acquiring all the information that we can gather from it.
Okay, so talking about this lady, in your opinion, if there wouldn't have been no stenosis in DOM, would you have performed FFR on a lady in the same procedure, or?
Yes.
Yes.
In non-STEMI patients in the FIRE trial, the investigator in most of the cases decided to perform the treatment of the patient in one procedure, whereas for STEMI patient it was different because they used mainly angiography-derived FFR in the STEMI setting, so that if the physiology was negative, the patient had not to come back to the cath lab for a negative FFR. But in the setting of non-STEMI, if there is no creatinine increase and you can do more than one vessel in one procedure, the main way to go was to perform everything in one single procedure.
Yes,
so because the impairment of the microcirculation is lower compared to STEMI.
Yes, and we also have to remember that in older patients, another invasive procedure with another access, maybe you have problem with your radial artery, this is also lady, and so on. So we're talking about almost no contrast for an FFR, so I agree with this. Another question, in your clinical practice, in which cases would you prefer to perform complete revascularization using a staged procedure in older patients?
Yes, again, I think that if you had the troubles in the treatment of the culprit, so you had to use a significant amount of contrast, those are in the FIRE trial, more than 60% of the patient has at least moderate eGFR reduction. So in those were the cases where you decided to stage the treatment of the non-culprit, or if you, for example, the non-culprit is the left main, so you want to have the time also probably to perform imaging, and you want to fix the culprit first and then to use a stage procedure to perform properly PCI, because in older patients we know that you always have basically cheap procedures. So if you have more than one vessel, if you have a left main included or a significant bifurcation and you want to stage the procedure, it can be reasonable, especially if you use a significant amount of contrast to perform the treatment on the culprit lesion.
Okay, thank you. I think we can close if we don't have any other question to read. Thank you, Vincenzo, for your interesting case. And thank you so much, Simone, for your tips and tricks on older patients. And thank you very much, everybody, for your participation. See you at next clinical corner, statistical corner, and see you at GISE also. I think, Simone, we will meet on face again.
For sure.
Thank you so much, everybody. Bye.